Okay. I'm joined today by Dr. Jose Szapocznik from the University of Miami. Dr. Szapocznik is one of the founders, contributors, and developers of brief strategic family therapy, and just want to kind of pick his brain a little bit, talk to him a little bit about um, what has been going on with brief strategic family therapy, how the model developed, and things like that. So tell us a little bit about your involvement with brief strategic family therapy. Kind of give us kind of a 30,000 foot view of it.
Yeah, goes back to 1973 um, when I was hired at the University of Miami to study uh, the problems of Latinx populations at the time, and mostly adolescents with problem behaviors and their characteristics and how they differ from the mainstream population. And so one of the things we identified very early is that there were intergenerational conflicts that had a acculturation type of flavor, where parents were less acculturated than their children. And so when we thought about a therapy, we needed a therapy that could easily manage intergenerational conflicts. And then I did a study of the cultural characteristics of the Latinx population compared to the mainstream population.
Mhm.
We found that the Latinx population was very present oriented. They had urgent problems that wanted to be solved right now, that they were looking for a therapist that was a leader and sort of help them to solve the problem. They didn't want somebody who said, well, you're going to solve the problem. You do this. You do it by yourself. They wanted somebody that would provide some guidance in a sort of traditional Latin X cultural perspective, that they want authority figures to provide guidance and guidance in solving current problems, what's going on now. They didn't want somebody who's asking, what happened to your when you were a child.
Yeah.
And so these qualities of this newly immigrant population with major adjustment problems were very clear. And so our team started to look at therapies around the country and to try to find a fit. And one of the places they found a very good fit was at the Philadelphia Child Guidance Clinic with Salvador Minuchin doing structural family therapy, and Jay Haley, who was born in Puerto Rico, doing strategic family therapy. And our what we did as a team is we looked at both of these, structural and strategic, and we blended them and created what we call brief strategic family therapy. It was a therapy where the therapist takes a leadership role and addresses uh, urgent problems of the family. And one of the taking from structural, which looks at interactional patterns, one of the things that we wanted to do was to work with what we could see. And one of the things you can see in a family is how family members interact. It's not a black box. You can see in front of you how family members interact.
Mhm.
We chose to work on those interactions that were linked to the presenting problem because our families wanted a brief therapy. They didn't see themselves being in therapy for a long time. They were seeing us somewhat like mechanics. I come in, you fix my problem, and I leave. So it was very helpful to be able to say to families, um, and we were able to better retain them when we're able to say, this is a 12 to 16 week treatment, so it's time limited, and we will work on your immediate problems. So that's how pre-strategic family therapy emerged from our experience with the population and borrowing from Salvador Minuchin and Jay Haley, who were both Hispanic therapists born in Puerto Rico and Argentina, who are working with African American and Latinx populations in Philadelphia.
Yeah. So I love the cultural the description of the cultural landscape in which this emerged. You know, you've got primarily identifying Hispanic therapists, Salvador Minuchin, Jay Haley, who break out these models, who develop these models in structural and strategic, and your blending of these models specifically for that kind of Cuban American and Hispanic milieu, social milieu in Miami and Southern Florida. Um, you talked about the leadership role that the therapist plays in BSFT. Um, are there other hallmarks of that model? One of the things I'm specifically interested in is what's the role of emotion in BSFT? You know, one of our evidence-based models is that emotionally focused therapy. This model, BSFT, is also one of our very strong evidence-based models that's probably a lot of people don't know about, but yet it's widely embraced in social service agencies across the United States. I'm here in Minneapolis, and I've talked to several of our human services areas that say this is the model that we work from because of how effective it is. Can you talk a little bit about the role of emotion and in contrast to you know, like a sole focus on emotion?
Well, we work with cognitions, emotions, and behavior,
Mhm.
and with them in a sequence. So our change process, what we call the change process, is comprised of those three elements. So going back a bit, we first diagnosed the interactional patterns in the family that are not working for the family and seem to be linked to the presenting problem. And then what we do when we are ready to help families try out a new behavior, we first highlight some aspect of the behavior. We we create a change, we create motivation for change by reframing, and then we give the family a task to behave in a different way. So we don't use any one of them by themselves. We always use them in a sequence. So as a lot of therapists will say to a family, well, why don't you speak to your son? Mom, why don't you speak to your son? And we find that doesn't work nearly as well as saying, Mom, I notice how frustrated you are when your son speaks to you like this. Frustrates you because you really care about what he feels and has to say about you. Let your son know that you get frustrated with him because you care. So that's the change sequence.
Mhm. Well, I often think about the traditional strategic therapy from the MRI, the Milan groups, as as trying to outsmart problems. And I find that many of my beginning students don't like that because it doesn't seem like what they are prepared to see a therapist do. Is there that same kind of emphasis on outsmarting the problems in BSFT as you see it?
I Not really. Um, I would say that we try not to dwell on the problem. We try to transform the experience of the family. If you call that outsmarting the problem, I wouldn't, but transform the experience of the family so that when they interact, they are already interacting from a different experience. Instead of being angry and frustrated, being caring, being connected to the positive affect that's behind the anger and the distrust.
Would you say that the main intervention is that reframing?
Reframing by itself is not enough in our view. So again, it has to be a sequence. So there are therapists, family therapists that are reframing focused. Basically, they change the meaning of interactions. But we change the meaning of interactions so that families are able to carry out a task that we give them, to behave in a new way in which the other person will be more open to listening to them. Mm-hmm. So tasking and changing behavior is a critical component of our therapy. And I can go back because there's another critical component that you may not be thinking about. One very important component of the therapy, and the first thing we do is we diagnose interactions. So we pay attention to which are the maladaptive patterns of interactions that are not working for the family. And we do that in 5 minutes. As soon as you let a family interact, you see it. So it's not like it takes 3 sessions. It takes 5 minutes to see what happens in a family, because the patterns of interactions are so ingrained and so repetitive that they're emerging from the group. And so once we diagnose what are the maladaptive patterns of interactions, then when we engage in a change sequence, we're trying to change one of those patterns of interactions. We choose, you're strategic in which one you choose to intervene first. That may be a good entry for this family. We're also strategic, and what makes it one of the elements that makes therapy breathe is that we're focusing on interactional patterns, because a family has 100 contents they fight about. There are usually about 4 or 5 interactional patterns that need to be changed. So there are very few, and that makes therapy much briefer.
And you're saying that within the first 5 minutes or so, are you just getting to know the family in that first 5 minutes, and then you're seeing these patterns interact, or how do you elicit the pattern?
If you start by saying, "Tell me what brings you here,"
yeah,
the first thing you're going to see is who is the speaker for the family, who's the leader of the family. Well, my son is using drugs, always gets home, never does. And I might say, "Okay, Mom, would you say that to your son right now?" So I try to create an enactment,
right,
to help behave now in the therapy session the way they might at home. So Mom probably will say, "Well, I've told him 1,000 times, yes, but I want you to do it here where I can see it and I can help you." And the moment Mom starts to tell the son how she says it, it's going to be in the same way as she says it at home, because it's ingrained. She's done it 1,000 times, and the son is going to behave in the same way that he usually behaves at home. And if that is going to come in and undermine Mom, it's going to happen right away. So very quickly, you have an interactional pattern that emerges. You create an enactment of family behaving with each other where you can see how the family interacts. And that takes 5 minutes.
Yeah.
But you throughout, you're always diagnosing.
Right. You're always seeing those interaction patterns. You're probably working from an internal hypothesis and getting that confirmed, or you're having to tweak it a little bit based on what you're seeing.
Yeah.
Yeah.
Well, we basically first see
Yeah.
what there is, and then that becomes our hypothesis, what we've seen. Now, that may change with time. You may see other aspects emerging over time, and then you tweak what you think is the interactional pattern that's most problematic.
Yeah. What would you say is I know that this model has been adapted everywhere. Can you say a little bit about the research base for this model?
Yeah, we've done a large number of clinical trials, um, and we've also done a lot of work in looking at creating a categorization system for interactional patterns. So very quickly, we can classify interactional patterns according to our theory in terms of um, organization, uh, psychological emotional distance, we call resonance, conflict resolution style, the rigidity of the livelihood. So there are a number of variables that we've developed that we use clinically that we very clearly can define in our language what's the interactional pattern that seems to be related to the presenting complaint.
Mhm. Uh, in contemporary practice, some family therapy practices, they talk about the not knowing position. My sense is that this, much like structural and strategic family therapy, that the therapist goes in with a model of what healthy interactions look like within a family. Would you agree with that?
I do, but that varies with culture.
Yeah.
And I have a rule that, first of all, we have to understand what's the culture, and it's going to look different. In some cultures, men are very powerful, and that's not questioned. In some cultures, men, fathers are or are not involved in child rearing. Uh, in some cultures, the psychological distance between people is much smaller, like Latins are much emotionally closer to each other than mainstream populations. And so we have to understand the culture of the family, the history of the family, understand what may be cultural, but at the same time, even if something is cultural, if it's creating a symptom, if it's not working for the family, we have to help the family change. So some things like a father not being involved at all in child rearing, and if that's creating a huge burden on the mom, or the mom is not a person who can by herself create order in the family, and you have to bring the dad. If it's a dad who never able to express emotions or feelings or reward the children, you may have to change that. If it's a parent who is always negative, and negativity sometimes works well with small children. When you tell a small child, don't do that, you're a bad boy if you do that. That may work until the child is 12 or 13, But by the time they're 14, they're going to rebel if that's what you continue to do. So even if it's cultural, at some point you have to help the parent to develop a parenting style that's going to be more effective in the social context and cultural context in which a child lives.
Yeah, I love that. So always striking a balance between what is culturally normative and adaptive within the family, right? And so there may be a period of time where this is good and it's sanctioned or it's supported by the culture, but there may be times when you have to push a little against that based on the family's goals and where they want to go with their family.
Exactly.
Yeah. Where do you see the future of this particular model going? I know because I know there's been a solid research base out there, and I think you're well beyond having to do random controlled trials and clinical trials for this to be known as effective. But where do you see this model going? What is the cutting edge for the model?
Well, the cutting edge in the last few years has been in implementation. And we've developed based on the BSFT is a model for family systems. And the concepts work very well in systems. So we generalize that to organizations in which BSFT is practiced in community agencies and in their support systems, their funders, for example, and the regulatory agencies. And so now when we 30 years ago, we used to go in and train therapists, but now that's a small part of the effort. The effort now is in implementation science, in how do we work with the organization for the organization to support the therapist doing BSFT, following BSFT rules. How do we work with funders so that funders support BSFT? How do we work with regulatory agencies or welfare agencies? So we really think of implementation as multi-systemic, and we have to work with all the systems so that they function in a way that allow us to do BSFT with adherence. And one of the things we do, for example, is that we place the CEO of an agency, or if it's a very big agency, it might be the clinical director, in the role of being responsible for adherence. We do all the technical supervision of the therapist, but if the therapist is not adherent, it becomes the agency's responsibility to ensure adherence. We provide the technical support, because what happened before when we didn't do that is that we tried to enforce adherence, but we had no power within the agency. Mm-hmm. We utilize the power structure of the agency. We have to work with funders because fee for service doesn't work for BSFT, because a lot of the work we do is not just in a therapy session. We have to work at engaging family members outside therapy sessions. We have to work with welfare system or juvenile justice system. And all of that is not reimbursable fee for service. So we always work with funders to capitate. That means that they fund a therapist, and a therapist has to complete a certain number of cases a year. So they're not being paid by hour, but by cases completed. And that's part of what contributes to the success of the therapy.
And has that implementation been difficult for agencies, or are they pretty much on board with it?
Well, at the beginning, it was very difficult. But as we have shown success,
yeah,
we're more able to go into agencies and into funders and say, this is what has worked. And And before we contract with them, we get them to agree to the implementation model. So we don't contract with an agency or a funder who's not willing to use our implementation model.
Yeah. I love how you describe this and focusing, like the next chapter is focusing on implementation, because I think for so many people who may be watching this video, they're thinking about, well, how do I practice as an individual practitioner? What I love to tell my students is that BSFT has done the research, and the model is sound. And I love how you're explaining kind of the future of BSFT and those capitation models, and how to get entire agencies kind of on board so that the most number of families can be served. Yeah,
And serve successfully.
serve successfully. Yeah, maintaining fidelity to the model and things.
And I recognize that in private practice, this is a challenge because private practice is based on fee for service. So all of the work we do now is with agencies and funders. We don't train private practitioners. They can learn it if they want.
Right.
They just can't do the pure model because it's fee for service. They can't afford to spend all that time outside of therapy doing the work that needs to be done in order for the therapy to be successful.
And Jose, it also sounds like you're describing a team approach. That's not just one therapist working with these families, but that you have support staff and things like that that are doing outreach to families. And is that correct?
No, it's all done by one therapist. So, excuse me a minute. The joys of working from home.
Okay, yeah, right.
Challenges. So we place a therapist in charge of all aspects of the case. So if you have to engage the family, that's a clinical process. That's not a social work management issue. Now, in some places, there are social workers that are bachelors of social work that are attached to a team of therapists to help with social services that a family may need, where families are in very poor environments and they need housing, they need medical care, food. And so some places that may be appropriate, but the therapist is always the person in charge of the entire program.
Okay.
And anything that's clinical, such as engaging family members, such as working with a juvenile justice or welfare system so that they know how to intervene in ways that are consistent with BSFT. That's all done by the clinician.
Yeah. Well, it's been a pleasure to have you talking a little bit about this model, BSFT, Brief Strategic Family Therapy. Dr. Jose Szapocznik, one of the founders of the model, and graciously giving us time today. Thank you so much. Appreciate your time, and and you may have other people contacting you and your organization to get more information about this training. But one of the things that I'm trying to do is get the message out there about this wonderful model as well.
Thank you so much for the good work you do. Bye now.
Thank you, Dr. Szapocznik.